little bit of a grounding before we hear from our panel speakers. Next slide, please, Kira. Before we begin, I'd like to take a moment to acknowledge the traditional custodians of this beautiful land we get to live and work on. I'm here in Noongar Budja here in Perth. I know I'm thinking there are people in other lands. I'd like to pay respects to elders past and present. I would like to extend a very warm welcome to any Aboriginal and Torres Strait Islander peoples who may be here. Whenever we gather to talk about health, it's really important that we always keep at the top of our mind and in our hearts that there is an unacceptable disparity in health outcomes between Aboriginal and non-Aboriginal people, that we're always hoping that digital innovations will make things better, but we want to be on the lookout that they ain't making things worse. Next slide, please. I'd like to just take a moment to recognise the importance of the lived experience voice to be at the decision-making table. I've actually borrowed from our electronic medical record consumer charter that we co-designed in 2019, and just say that we want to be at the decision-making table as partners in the design, development, implementation and evaluation of an electronic medical record system for WA. This is not something that's happened necessarily in other states and territories to the extent that we would like. I would just like to also acknowledge the members of the EMR Consumer Reference Group. We have some of them here. We have Nigel, we have Robert, we have, who else? Who have I missed? I can't see.
Tim.
I know there's Tim, sorry, I can't see everybody on my screen. So we have a group of engaged consumers who are working on the EMR program. And next slide, please. So just to frame this discussion, we know AI is a really big topic, but one of the reasons we really are wanting to bring these conversations together is we want to think about it in relation to the electronic medical record program that we're doing in WA. It's a really big program. There's a lot of momentum. We are the last state or territory in Australia to get an electronic medical record. Without an EMR, there is no AI. But I think, you know, we really want to try and keep our thinking about what could AI mean in relation to an electronic medical record. Next slide. I did talk a little earlier about an electronic medical record charter. So this is a document that has been drawn up. So it is a WA health document, but it was designed by consumers and co-designed a couple of years back before we actually got the funding. And this document is used in the EMR program to help drive the work that is happening. So you can see those main headings. Consumer involvement is the number one. We cannot ever take it for granted, and we have to constantly make sure we are at the right tables. The safety and quality is one of those really key things around digital health. As I say, we hope these things are going to make things better, but we hope they don't make things worse. Security is really key. Transparency, choice and control, accuracy and equitable care. Next slide. I just wanted to highlight that in West Australia, in the Health Department, there is an AI transparency statement, and the EMR Consumer Reference Group did provide input into this statement. And I might ask you a bit more about that in a little while, Peter, but my understanding is that sits under the area that you work. And I just wanted to highlight that I think often people think these topics are very dry, but we as consumers tend to be very interested in these. And I think there was more consumer input than any other type of input into this transparency statement. But I thought I would also add in, Kieran highlighted an article that he found on the conversation about AI transparency statements. And again, it's something about, you know, this is because all this is rapidly unfolding, you know, how useful are transparency statements? That they're important, but are they being done well? So I just thought I would put those up. I will obviously share these slides after if you're wanting to have a closer look at things. And Next slide. I wanted to talk just very quickly about some resources I thought you might want to check out after. I know everybody's busy, but Health Consumers Queensland, our Queensland colleagues, they did a series. It was called Future Care. It's on their website. You can just jump on it and have a look at any time. There was a few different webinars, but this one on consumers who actually are involved in AR projects, I thought I had another listen to it because I listened to it at the time, but I re-listened to it and I thought, you know, these two consumer reps that got asked that question, you know, what's that one thing that you think consumers really need to think about? And Matthew Ames was talking about, you know, what problem are we trying to solve? And that we need to carefully weigh up the risks as well as the benefits. And the risks for vulnerable populations may be higher than first considered. And the other fellow, I quite like what he said. He was talking about consumers need to get informed and get ahead of the wave. We could surf the AI wave to our benefit. And I think that's often how I feel. I think there could be a lot in this for consumers. The next thing that I wanted to highlight is this resource, which we will send out the PDF, and actually Eve will be able to talk about this because he was very involved in this project, and I had the opportunity to be on the consumer reference group that created this resource. It is a really good one. So, you know, it sort of highlights the things that consumers are interested in, you know, efficiency and access, that it doesn't impact human connection, accuracy and safety, data quality, consent and choice, bias and equity, privacy and data security, knowledge and education, monitoring and evaluation. So it's quite a good resource to have a look at, but just thought it was interesting again, because we're trying to think about, this is a really big topic, but we're trying to think about what do we need to think about as consumer reps. And on that very same resource, on page, I think it's page 17, on that next slide, it talks about examples of AI use in healthcare, which I think is quite handy. So it just sort of lists what some of the main uses are. And that last one, writing notes and summaries of consultations, is something that we'll be talking about in the panel discussion using a WA example. So these are just resources for you. We will send them through to you, but I suppose if there was just one thing I could say, sometimes these topics seem big and they seem difficult, but I think there's a lot that we need to that we can do as consumers, and I think it's really just to be thinking about these principles. So, without any further ado, if you wouldn't mind. Just that next slide, just so I can just introduce our speakers. So we have 3 speakers, 2 from WA, but we have somebody from New South Wales, Wollongong. Isn't that terrible? I should know that. But we have Eve Aquino, he's a physician and a philosopher with expertise in empirical bioethics and philosophy of medicine. And his program of research currently focuses on the ethical, legal, and social implications of artificial intelligence applications in healthcare. So he's a research fellow at the Australian Centre for Health Engagement, Evidence and Values. That's Achieve for short, and that was that project where the resource that I showed in the previous 2 slides was emanated from. And before that resource was done, they actually did do a whole citizens jury on the use of AI in healthcare, which I've put links in that slide as well so that you can have a look after. And from WA, we have Peter Sprivelis and Professor Peter Sprivelis, I should say. So he's WA Health's Chief Information Officer. And we have Dr. Ryan Bayer, who's an emergency medicine specialist, and he's working on projects. He's leading a AI scribe project in WA. I'm going to pass first to you, Eve. I just wanted to ask, I know this is a big ask, but would it be possible with all your knowledge and research, if you could summarise the issues that consumers need to be aware of and advocate for in relation to ethics and AI? I think we all have blind spots we're not aware of. We're often the one or two people who are sitting at the table. What do we need to be thinking about and advocating for as consumers?
I can start with a quick one. I think it's going to be knowing and clarifying what patients' rights are when it comes to giving consent to the use of artificial intelligence in their care. I understand this is an ongoing issue. There's a lot of clarification that needs to be done federally and statewide. But I think as consumer representatives, we need to be able to have clarity. Can patients say no to the use of AI in their care? And will that affect the quality of their care?
Mm. That's such an interesting opening thing. So, can patients say no, and will it affect the quality of their care? That's one of those questions we need to be thinking about. Is that right?
Yeah.
Yeah. I was wondering if you could share a little bit about the experience of, working on the citizens' jury around AI in healthcare.
So we conducted Things PIP, and it's a wonderful project that we were able to conduct with the funding from the National Health and Medical Research Council. We conducted a citizens jury with 30 Australians randomly selected from different states, and we ran yeah, sorry. So we had 3 weeks of information session, and then it culminated in a 3-day face-to-face session where we asked the 30 Australians to come up with recommendations about using artificial intelligence in healthcare. And one of the things that they really wanted to highlight is making sure that there is oversight with the use of artificial intelligence in healthcare, that there is support not just for the patients, but also for the healthcare workers who have to directly engage with these technologies. They also want education and communication with patients and consumers and direct engagement with the community. They want to make sure that if we're going to use AI, that it's better, at the very least, performs equally well or better than human clinicians. And they also want to make sure that it does not compromise the humanity of clinical interaction. I think that's what people had in terms of an image, is that once people start using artificial intelligence, that you're going to see less of the human clinicians.
Yes, I think that is that's something that comes up a lot. Um, Thomas has made an interesting comment. He said perhaps it's not quite as simple as opting in or out of AI use in one's healthcare, and that perhaps individual patients might wish to opt in to only partial use of AI in their case, and that every patient is unique. So I think there was agreement from another attendee who said realistically it's going to be a lot of nuance and customization ability in AI. I'm wondering, Peter, can I go to you? If we sort of reflect on this conversation around ethics and AI and that concept of consumers being able to opt out and opt in, what's your thoughts?
Okay. Yeah, so you'd be aware, Pip, and people should be aware that I've been overseeing the creation of the frameworks and policies that WA Health is implementing to support the implementation of AI. Sorry, I'm coughing for some reason all of a sudden. I think the first most important thing to understand is AI is not one thing. It is, there's literally thousands of different types of AI technology. For me, the thing that differentiates AI from other tools that we use to automate processes, be they clinical processes, be they health service ops like patient flow processes and scheduling processes, or be they corporate processes, is that you can't look inside the box with an AI tool. Whereas every other tool, we usually can map out the algorithm about how this thing works. That's a differentiating feature, largely. And from my point of view, there is no element of healthcare that's not going to be impacted by some form of AI. So some of them um, are so specific in their use that there really isn't a question as to whether there's going to be an opportunity to either to obtain informed consent for the use of AI. If I think about one example that's out there at the moment is the use of AI to give an early warning as to whether someone's starting to deteriorate with a specific AI model that's looking at patterns in terms of heart rate variability in an ECG monitor of someone in hospital. They can detect a problem and alert a clinician that perhaps they need to go and look at that patient and understand what's wrong with them much sooner than a clinician waiting for more obvious changes like their heart rate going up or their blood pressure falling or they're experiencing shortness of breath. So there are some forms of AI which are embedded in our technologies, which there isn't really that opportunity to offer informed consent. But that said, it is important that any clinical decision must actually be based upon an understanding of transparent disclosure of the use of AI in what we're doing. And that needs to have quite detailed metadata about what model was used at what time and when, because these things are changing very rapidly all the time. But at the other end of the spectrum, Ryan will tell you about the use of AI clinical scribes, and that's one where it is routine, and the opportunity is there to describe what this technology is doing to support a clinician do their clinical documentation and seek consent, and that is routinely done. And certainly has been my experience as a patient outside of the WA health system, sort of seeing various specialists because I'm so old and clapped out. So some really interesting issues there. I think a really important point, apart from the transparency, disclosure and consent, is what are we doing about our clinical governance models to look at this? I sit on the Australian Safety and Quality Commission's Council for Digitally Enabled Care, and the general interesting thing about clinical care is that we already have clinical governance models to support the introduction of dangerous things into healthcare. We introduce major trauma by appointment. We call it surgery, and we introduce poisons all the time. We call them drugs, but we have processes in place to evaluate the evidence behind those, monitor whether those are doing the things that they're supposed to do, and escalation pathways that go all the way up to the international level via the national level when those things don't seem to be working the way they should. And for mine, one of the most important governance mechanisms, given there's so many different forms of AI, is that we need to embed AI expertise into those clinical governance structures, frameworks, and groups that get together to try and understand how what could be the problems that might arise with a particular use of AI in a particular setting, and what are the best ways of monitoring for those potential outcomes and using our conventional frameworks for managing those as we would for a new kind of operation or a new kind of drug.
That's really interesting. I must admit, I'm already starting to find myself getting a little bit confused between, because I know that some AI, like you were talking about drugs and surgery, as things that we do, and especially with surgery, we put prostheses, put things into human bodies, and so the TGA looks after drugs and the TGA looks after medical devices, and it also is now starting to look after AI, but there is a bit of a there are some things are more, I don't know, say like your watch where you're doing your steps, that's not considered to be something that they would need to look at. But if your Fitbit is sending data to your GP that they're using, I know that's not happening, but if that were happening, then that would be something the TGA have I sort of got that right?
Well, it's a horse for course thing. The TGA has to first work out whether this usage is a therapeutic device. So there's a lot of software bundled in devices. So an example I gave is a clinical monitoring system. That is definitely a clinical device according to my understanding of the TGA's definition. And so they would be looking at the evidence around the use of the embedded AI tools with that. Whereas another example, let's say a AI tool that's being used to support a clinician evaluate breast mammogram evaluations to make sure they don't miss an early cancer or something. That isn't a medical device, and so that comes under more routine clinical governance. If it's a research type project that someone's trying to develop one of these things, it sits under our standard human research and ethics frameworks. But if it's something we're buying off the shelf that someone else has already published all the evidence for, and that evidence is good, and we're comfortable that we don't have a different population to the people that it was trained on, and we're otherwise comfortable with the tool, then it's our standard clinical governance groups that need to look at that, just as it would with a new kind of procedure or a new drug.
Yeah, because one of the questions was, around governance, can you elaborate on the regulatory controls and standards and parameters in healthcare when AI is involved? What you're saying is they are very similar to a new device or a new drug. It would go through the same kind of
Yes, we don't want to
process.
reinvent clinical governance wheels when we've already got them. That said, we need specialised expertise on those clinical governance groups so that when an AI scenario is part of a new thing that's being implemented, you've got the right expertise around the table to say, well, these are the risks you've got to think about with this one, which are different from a new drug or a new procedure. These are the things we need to do to monitor it in a robust way. And these are the reporting mechanisms that we need to put in place to make sure that we can have confidence that we are tracking this thing properly. Yeah.
And I'm just wondering, Eve, if in the conversations you were having through the citizens' jury around AI, what did they talk about this sort of idea of, I guess, consumer oversight and clinical governance? And was there a sense of what that could look like?
No, there wasn't any specific platform or framework that people came up with because it's quite a short deliberative activity. But they did want to make sure that community members are involved in making decisions about their own care and how AI will be involved. But I also wanted to comment on governance of AI. There is not a lot of clarity, for example, with how medical device is being defined at the moment in terms of AI technologies such as digital scribes. So digital scribes technically are administrative tools. They're not clinical tools. But based on the definition of the Therapeutic Goods Administration of what counts as a medical device, there is an item there that states something to do with therapy or diagnosis. So even if digital scribes are not designed to diagnose or to suggest therapy, it is in the feature of a clinical record to involve those information. So if a digital scribe is trained on medical records that include information about diagnosis and treatment or management plan, statistically, a digital scribe will come up with a diagnosis even if you did not ask it to, because of the probability that those kinds of information are part of the records where that scribe was trained on. So there could be, by design, an administrative tool, but in practice is actually a clinical tool. So this is problematic because if you say that this is just an administrative tool, it doesn't have to go through the review process that a usual medical device will have to go through. It doesn't need the kind of evidence base that a pharmaceutical product or a new medical device will need to come up with in order to be approved by TGA. So a lot of these administrative tools can actually impact on clinical care. So that's one of the things that people miss, is that if it's something that doesn't look necessarily or traditionally like a medical drug or medical device, they don't have the evidence base. So as consumers, I think that's something you need to push for. What's the evidence that this technology works? And what's the evidence that this technology works for Australians and this technology works for populations that are historically marginalized, whose information is not as widely available as majority of the population.
That's really helpful. Peter, you
There's
are correct.
probably a slight addendum to that as well. If I think about two large types of AI, you've got your narrow purpose use case AIs, which are usually pretty reliable at what they're doing. Really good, like the diagnostic ones for diagnostic imaging are fantastic. They're at least as good as humans. What we know about the large language model ones that are underpinning transcription, we know they're pretty good at voice recognition. They're pretty good at summarizing information, codifying information, and they're also pretty good at translation, but they're not perfect in any means. And so that's why they're prone to hallucination and prone to including things that someone hasn't said in an interview. And that's why it's so important that there is proper clinical review of clinical documentation. And I'm not so concerned about that, about the general surgeon who I had to go and see a few weeks ago. I think he knows what he's looking for and what he's documenting. I'm more concerned with the issue Eve pointed out there with a junior doctor where they might use a hallucination as diagnostic guidance. And I think it is really good to point that out.
I think from consumer perspective, one of the most useful things that we get is a summary. So it might be a discharge summary, for example, and that is an incredibly useful piece of information for us. However, am I right in thinking it is nearly always a junior doctor who is doing that, who may or may not have ever seen you? Have I got that right?
Oh, this is a real bugbear for me. And it's one where I do think there is a role for the use of AI tools and looking at whether, and some people at one extreme, you could say, why are we bothering trying to do a summary to another clinician when in actual fact we can send them the information. You know, My Health Record is a place where we already send a lot of useful information for people. Why are we bothering in trying to get junior docs to do some sort of summary, which they don't seem to be able to do very well? They cut and paste reams and reams of stuff that no GP ever wants to read and then vomit that out. That said, I think the AI tools are quite good at doing a plain language version of a summary that a clinician might write for themselves, which is useful, which is also useful as a checking thing that a health consumer can use to see that the AI has recorded appropriately in its summary for you what you thought you were getting out of the consult. So there's an opportunity for health consumer review there. But yes, you're right. It's a big problem, but I do think there's an opportunity for AI to assist in the process of discharge summary creation. And in my view, we should really be trying to find a way of taking junior docs who don't know the patient, don't understand the information out of the loop in actual fact.
So potentially, from a consumer perspective, we could get a summary from the actual treating clinician. They might be able to do something quickly using AI so that we might end up with something better than a junior doctor trying to, is that what I'm saying? That's a possibility?
Yeah, absolutely.
Okay. One thing I wanted to...
Sorry,
you go.
I just also wanted to defend junior doctors.
Sorry.
I'm in war with them at the moment, as you can hear.
I also did medical training, and I think when you're coming up, you obviously don't have the skills that senior clinicians have. And I think it is a process that we have to accept in any kind of discipline or specialty. You're not immediately given all these expert skills, whether it's cognitive skills, thinking skills, decision-making skills, writing skills, and summarizing skills. These are skills that you have to learn. So I think we need to also think, what are we giving up when we start automating this at the very early part of a person's career? So I think if we're okay with automating and saving time, those are great benefits, but we also have to be clear with the things that we're losing, about the trade-off, and what are the stuff we are willing to give up down the line. Yes, so I understand it's young clinicians are not perfect, and a lot of their summaries might not be up to par with a more senior clinician, but I think it's a process that we have to go through in order to make things better, in order for them to become senior clinicians and more experts with any kind of skills
How to
needed.
communicate. Yeah, good point.
I do want to come to Ryan in just a moment, but Peter, I just wanted to, just for our listeners, I just wanted to highlight, so you talked about, so at a statewide level, you are looking at doing all of the frameworks and policies. So I guess I just wanted to, like, and I know you do a lot of work nationally, like, do you have a sort of a sense of where WA is sitting in terms of adoption of AI, how we compare with our colleagues? Any insights like that?
Well, essentially, good artists copy, great artists steal, as they say. And so
Totally.
we did a fair bit of stealing from New South Wales Health in the development of our work, and they'd stolen a lot from Europe and
Yeah.
from the UK. And we've since obviously there's some bits and pieces that we had to nuance that relate to the requirements for reporting up to our local state government and things like that. But then our stuff we've subsequently shared with other jurisdictions so that they can also sort of use our information as well around the frameworks. And the basic bits of the framework are pretty straightforward. There are some technical elements that need to be dealt with. What's the cloud security issues that you're going to face and the cyber issues you're going to face? Have you done a formal, well-informed patient safety risk assessment around this? These are things we do for all forms of cloud-based technology we implement. But then what we then need to do is make sure we get people to look carefully at the AI implementation principles. Things like, have they got the governance processes in place with the right expertise on it? Have they thought about the biases in the models? And is it relevant for, say, an Australian Aboriginal population to apply these models rather than a white North American population? Have they really thought through the benefits and how they're going to measure them? And what are they doing about transparency, disclosure, and consent for those use cases where it is important that not only health consumers informed, but have the opportunity to give informed consent for the use of the tool? And for mine, that's really in the areas where it's going to affect any kind of clinical decision. In those settings, a health consumer needs to, in my view, give informed consent.
Yes, informed consent could be obviously a whole topic, and there's been some really interesting comments about how we capture consent and what that consent is for, because it's obviously consent for treatment, but also consent for use of information. I'm just going to ask, what has been the consumer involvement in the work you're doing, and what is it? Are there things that this very interested and motivated and informed group of consumers could learn about?
Yes. Well, in WA Health, what we did is we had a range of consultation both internally with WA Health, and then what we did is we reached out to the WA health consumers and asked them to review our policies, and particularly, as you pointed out, our transparency statement, I think, was a really important one to get the involvement from health consumers in development of that.
Yeah, so we feel like we did good with that. I haven't seen our policy though, so that might be something we can talk about after the session.
Oh, for sure. I'm pretty sure it's publicly available.
Cool.
I'll have to have a look.
Yeah, because I think I struggled a bit to find it, and sometimes those things are on the intranet, not internet.
Yeah, you may be right.
But I'm so sorry, Ryan. I feel like I've been neglecting you, but I really want to bring you in this conversation because what I wanted to ask you about is your experience of. So you've actually been leading a project around clinical scribing, and I know that you bring also an international perspective. So I just really wanted to ask you if you could just give us some updates and insights about what the work you've been doing. And you're on mute.
I was working on it. We're good. Yeah, great. Thanks, Pip. And listen, no problem at all. This was the conversation to this point, I think, laid great foundation of kind of stepping off into some of the specific sort of projects. just for setting the stage a little bit. So as an emergency doctor, in a health system that's been having more difficulties with things like overcrowding and hospital throughput, and from my line of sight, getting patients from the waiting room into the emergency department. That was one of the drivers to bring me into this role at the North Metropolitan Health Service in Perth, as the medical lead for digital transformation, was wanting to do projects and trying to see if I could find a way to have some impact. Now, that said, so how can you, so the question then was for me, what can I do that might be able to help this problem in some way? Clinicians spend 30 to 40% of their time on documentation. And in an EMR world or electronic health record world, you spend actually more than 50% of your time in front of the screen, the monitor in front of you. And so the amount of, so there's less and less time in front of the patient and at the bedside, unfortunately. And so trying to give some of that time back becomes very important. Combine that with back in 2010, which feels forever ago now, but I was the head of department of the emergency department at a hospital in the US, where we were going live with our EMR. And at the same time, to try and combat that issue of being more time in front of the monitor at the computer and less time at the patient bedside, we implemented scribes, but we implemented human scribes, which were very common and all across the United States, and especially in emergency departments, but also in many other areas. And it became very commonplace for a human, again, a person, to come in with a doctor to help document that session, to decrease documentation time, increase productivity, and to also improve kind of workplace job satisfaction. And they were very good at doing that. So coming back into this role, and trying to decide where I might have some impact, was trying to, because now there are these AI scribes, which are tools that can help to, again, voice to text and sort of create a transcription of an encounter, and then take that text and template it out into a usable medical note or clinical note. And there are limitations with that. Yes, there are sometimes it's not exactly right. Yes, you need to get consent. And actually, all of these things, interestingly, were also played a role with working with human scribes who were new to the medical world. You had to make sure that what they wrote down was actually what happened in the encounter, what you meant to be, what you wanted to have there. And so, interestingly, its history sort of is repeating itself, but in a very different way, for me at least. So, coming back to the beginning, so. It's taken me a year to get this project off the ground. And part of that was I was new to this role. I was new to figuring out these processes. And it was in part because it was a team of one to make this happen. So North Metro is currently in week 8 of a 3-month trial, using one of these AI clinical scribing tools to help with writing clinical notes. It's the first trial of one of these in WA public health, although there has been some work in the private sector. And so, yeah, to this point, we're currently in week 8 through 7 weeks. We basically got 20 active users. There have been 1,700 plus notes written and 19,000 minutes of conversation transcribed. And the initial feedback from the users is very positive from the clinician standpoint. And I'll stop there and let you ask me more questions.
I guess, so you said yourself like week 8 of a 3-month trial. What has the feedback been from clinicians and health staff, and what has been the feedback from patients and families?
So, great question, and I knew this was going to be coming. So from the clinicians, as I said, the feedback's overwhelmingly positive. More interaction with the patient, more present in the room with the patient, being able to engage more with the patient because they know that documentation is taking place. And so that has been very easy to see. Definitely, there's been some, again, decrease in documentation time. There's been an increase in workplace satisfaction, and so again, there's been a lot of, from the clinician standpoint too, one of the things we haven't talked about in this space is that there are a lot of clinicians have to stay late after their time. The clock has actually stopped and they have to finish all of those notes before going home. And that's often an hour plus. And that documentation is becoming less and less. And so they're getting some of that time back so that they can have a bit more of their lives back, and as opposed to sacrificing some of that for documentation burden reasons, if you will. On the consumer side of it, I had wanted in the beginning of all this, one of the things that I'd wanted to try and do was to have a consumer feedback option, to have, again, there's posters up in all the rooms, and I wanted to have like a QR code that consumers could get to and respond to get some more feedback from the consumer side. Unfortunately, again, I just, from a resource standpoint, wasn't able to make that happen. And so all of the feedback that I've gotten is from the clinicians that are participating, who have said that they've been getting better, more engagement from the consumers. And one other thing that I guess I would also try and do in a future study, but I'm not unfortunately capturing here, is, as you brought up earlier, Pip, there's a conversation happens, a transcription of that conversation is created. From that one transcription, you can use different templates. And so without increasing any time, you can have for example, a medical note of the patient encounter, you can have a referral letter that's created, and you can have a patient summary to give to the patient. That piece, I think, is very important, because previous evidence shows that in the emergency department population, for example, that 86% of what the patient is told is forgotten by the time they walk out the door. So that is one of the things. Yeah, exactly, because they're so overwhelmed. It's such a chaotic environment. They don't feel well, right? Like of course, it's a total setup for to just losing everything that was said. And so that's a piece of this that, again, with a bit more forethought, time, and energy, I think would have been very valuable. And unfortunately, I just don't know.
Yeah, so I'm going to take the because there's a question from Deb Ledica. So partly what she talks about, how will the impact on consumers be measured? I'm going to take that part of the question away, and I'm going to take it and talk to the EMR Consumer Reference Group and to our group after this session. We'll chew over that a little bit more, because that I think needs to be done. I'm curious, Eve, if anything in the citizens jury talked about evaluating the impact of the use of AI on consumers.
So not specifically evaluating the impact on consumers, but more of evidence in general. Not to assume that just because it works in one industry that it will work in healthcare industry. And we have seen, when it comes to like Silicon Valley kind of technology, there is that sort of arrogance that once it works in manufacturing, that it can work in healthcare. And we saw that a little bit with large language models. There was quite a quick uptake from some medical doctors, I think 2 years ago, when Open AI and ChatGPT was launched, for them to start using it in their clinical work without realizing that they shouldn't do that, and that that kind of technology was not designed for medical communication. And I think people need to understand that medical communication and clinical interactions are different from regular conversations and text, and that's why works being done by people like Ryan is really important in making sure that the technology is fit for purpose. But again, we do need to understand that there are things that we might sacrifice because of automation. So I think being careful about that impact, that's why we really need to study the impact of the technology, not just on the workflow, but also even on the skills of clinicians. It's different when automation is done by a younger clinician versus when it's done by a more senior clinician. So those things, know yet, if we don't study it in the wild, in the real world, we don't know what's going to happen. That's why we are like, consumers should really push for evidence and for studies to show that it's safe, it's effective, and it's really about the care of the patient. And one of the things that I'm always wary about when it comes to automation, including automation by artificial intelligence, is that great promise of saving time. If we don't change the structure, if we don't fund our healthcare, if we don't make sure that we have enough staff, if we're not paying our healthcare workers well and retaining them in the profession, one technology cannot change the fact that people are overworked.
Yeah,
And if
100%.
this tool, um, and we've seen that with the introduction of computers, even way before the introduction of typewriters.
Yeah.
If your measure is productivity, if your measure is money and capital, you'll find a way to overwork your healthcare workers, even with AI automation. So that's something I just want people to be careful about when making
Yep.
saving time.
I hear you. I want to go back just a moment to the consumer experience of scribes. And I just note, Erin put in the chat about, so in GP land, of course, it's different from the hospital world that we're talking about just now, but that, her GP uses a scribe and basically that it was the consent was handled well. I've had that experience recently too. And I actually kept my consent wording. I thought, well, that's interesting. I'll have a look at that consent wording later on. I think that, I think there's general feeling that people, because the consumer experience and the staff experience are linked together like a three-legged race. And so as you're rightly pointing out, Eve, when staff are overworked, we patients can see that and we are impacted by that and we don't like it. And I think, we like to think of these tools assisting that heavy workload. And like Ryan, you pointed out that clinicians felt that they were more present, and I'm sure that consumers felt that as well. But I also wanted to just circle back. There was another part of Deb's question that was interesting, and that was training for staff. So Ryan, I'm curious about, in this project that you've done, what training for staff was there to help them adapt to the new technology?
So the technologies themselves are actually fairly user friendly, right? So they're easy to use, which is one reason that they've caused such a ruckus. And they're transformational on many levels for many clinicians who have used them. And there's so much pressure. Even without my trial, quite honestly, I'm seeing increasing use of these tools just rogue within the system, right? Like, people are not waiting to ask permission, they're just going ahead and using them. And so really what I see, I see that the end state here is, at some point, all clinicians will be using these tools. It's a matter of how do we get from where we are to create all this infrastructure so we can get to that safely. And so I guess that's the that's the mindset, that's the sort of destination, getting from here to there. So in this particular POC, there were trainings from the vendor on how to use the tool. And then on my end, there were there was trainings and a participation agreement that outlined all of the expectations on our end of the POC that were outside of the vendor's expectations, if you will. And so outlining what the use cases are, the appropriate use, North Metro patients, et cetera, et cetera, et cetera. Outlining that patients, you do have to get consent. You are responsible for the notes that you are writing, and that ultimately, again, there's the human in the loop for a reason. You have to make sure that information is correct. And so it was ensuring that patients have the right to opt out, et cetera, right? So there was all of that information was communicated then with all of the participants of this particular trial.
Thank you. And I just, Jenny Bedford just had one specific question. Said, has this trial been shared with the wider community? So I'm guessing within the hospital service provider, health service provider land, it has been, but has it been shared further?
It's not done.
Because it's not done.
Again, I don't have my end POC evaluations sent out yet, not to mention any actual data to report there. I had in the middle of the POC, I got a little bit of proof of concept. I got a little bit of data, but the number of responders was only like 6 people, so it's hard to make great inference based on an N that small. So it's the end of the study where hopefully we'll get more meaningful data and be able to share that. But yeah, the intent is to share it more broadly, absolutely.
I can't believe it, but we're nearly coming to the end of this period of time with our speakers. I'm just wondering if I could just ask a question to each one of you, like, we're going to talk about what we think AI, what's the good things that we can think for as consumers with AI. Do you have, I guess we really just want to say, what do you think we should advocate for so that we can catch the wave of AI and surf it all the way into good health? I'm going to start with you, Eve.
Oh, that's a very big question. If there's one thing, I think that especially consumer representatives can advocate for, as I've said earlier, would probably be both the rights of consumers as well as the evidence. Does it work, and does it work safely, and does it work for the groups that they're intended for?
Yep. That's really helpful. Thank you. What about you, Peter?
Your clinicians can't
sorry.
answer. You do need to, if your clinicians can't answer, they need to be able to answer that simply. If there's no evidence, and you're not comfortable, clinicians should not be using something that they don't completely understand, especially when it comes to new technology. Thanks, Pip. Sorry.
Thank you. No, not at all. What
That
about you, Peter?
segues very well to me, because top of my list is literacy, both clinician literacy and health consumer literacy. I sort of view AI as no different from any other informed consent process, really. But for the use cases where we would normally expect clinicians to obtain informed consent. So, but informed consent relies on being informed. So that means the clinician needs to be able to articulate, as Eve said, what this thing is and what it's doing. And it has to be done in a way that a health consumer understands it as well. And it is important, as I said at the start, this isn't one technology. You've got the large language models and their various foibles, which I think will end up limiting their value. We're at the top of the hype cycle with those. But there's many narrow use case AIs which are really fantastic and are exceeding human performance in supporting clinical processes, and we're going to get a lot of value from those.
Informed consent is not done well now, I have to say, and 60% of the population have poor health literacy. I was just wondering, as you were having a look at all the New South Wales stuff, Peter, were you inspired by the health literacy hub and think, oh, we really must have a statewide health literacy hub in WA?
Look, I'll pretend to say yes, but I'll take that on board. I think that's a really, really interesting point.
There was a really interesting comment from Jenny Bedford too. She talked about could you utilise the teach back method in AI? That's one where you ask the person to say, what have I said, so that it can be clear that they haven't got it at all. So I don't know, maybe Jenny, I'll make sure I send through that to Peter afterwards. Ryan, what about yourself?
Again, this is a hard topic, right? I think that it's saying more or less the same thing. It's important to understand as much as you can the upside and downside risks to whatever's being proposed, and so it's a conversation between patient and clinician and it's a shared decision-making process. And so it's there's that balance, right? Like, again, if you're not informed, how can you be health literate if there isn't information coming your way? And so it's finding a way to have that conversation at a level to engage with the patient so that the patient is enabled to make the right decision or the best decision for him or herself, right? And so I guess while that is difficult to achieve, I guess I think that's the best way, and obviously being upfront as you can and transparent as you can with how what this thing is, how it works, and what it's being used for, and why you're using it.
So I didn't get to all of the questions in the chat, but I think I got to a lot of them, and we will also we're obviously going to have our chance to deliberate once we have farewelled our speakers and had a comfort break. So I just wanted to just on behalf of all of us here in the Zoom room, just wanted to thank you so much for making the time. Eve, Peter and Ryan, thank you so much for sharing your different perspectives on this really complex topic. I've certainly learned a lot, and I feel inspired with a whole lot of new projects, and we will be in touch. And we'd love to share with you our consumer deliberations that come out of this session.
Oh, they'd be really welcome.
Yeah,
Thanks for
Absolutely.
the opportunity.
looking forward
Thanks
to that. Thank you
again.
so much.
Thanks,
Thanks,
everybody.
everybody.
Peter, thanks, Ryan. Bye.
Thanks, Eve. Thanks, Peter. Thanks, Pip.
Oh, so I do apologize. I did not get to all of the questions. I was trying to. Some of them were were answered, as a bundle up. I think I feel like Sasha, you were. I was trying to follow along, but I think I might have missed. So I just wondered if you wanted to have a chance to talk to your things, and then we'll have a bit of a break before we get into our deliberations.
Yeah, thanks, Pip. That's great. I probably approached this a little bit differently when we were coming today. There've been a lot of federal and state government documents released about how much of what we've discussed today should be done.
Yes.
And you may or may not agree with it. I've put the links to a lot of those documents in the chat, so please go ahead and have a look.
We'll absolutely share those as well after.
Yeah, and having reviewed them, I'm kind of concerned about how much organisations are adhering to them or not, and that's where a lot of my questions were coming from.
Gotcha.
Yeah, so basically, and I am approaching this probably from a little bit more of a mental health specific rule. So for example, there's a national standard document that's been released called the National Safety and Quality Digital Mental Health Standards. Have they been incorporated into their tender that's about to be released? And if they haven't, I think that's a good space for a discussion, because in there, one of the requirements is co-design with consumers from the very beginning. And when you release the tender, that is the very beginning of this. I did have some technical questions, which we can move on for. My main concern about the technical part was a use of Solus and how fit for purpose it is, and from a clinical perspective, how much that impacts care, and particularly that there are certain legislative requirements the organisations have to adhere to. And at the moment, you try to audit it through the digital health records, we appear, the departments or whoever's delivering the health service appears non-compliant. But that's not due to the EMR or AI, it's due to the fact of the current state of the programs. And if we don't improve those, how are we going to get good at digital health? So for example, if the Department of Health was to purchase an entire new system, you could build it from the ground up. It would take 3 to 5 years, and you'd have to migrate in all the current data. Very complex, very difficult. The other option would be to purchase a bridging program where the EMR sits on top of all the programs you've currently got in Department of Health and sucks it up that way, so you've got one face. But then it's going to be limited by current flaws in the system. So that's where I think the compliance with a lot of these governance documents is important. The other one I put up at request of someone else was the state government policy about AI. And basically, as any government department builds any AI tools, they're supposed to follow this policy. One of them is a self-assessment. And the other question I put in there was, what will be the process of addressing contestability? And just to trim down what's in the policy, anybody who has a stakeholder interest in whatever the tool is, how it could affect their care. So that's where I see consumers being pulled in. They ideally are presented with, this is what our plan, this is what I think we should do. And we then have the opportunity to contest it. And it's not clear to me through the policy documents how that's going to be implemented as things are being built, assuming we are building them and not purchasing. But my view is, even if we're purchasing, you would be then contesting, do we need that particular tool or some other tool? I'll just stop there for the moment. I could go on for ages.
Yeah, that's great, Sasha. And so I will just briefly say, so we are in the process of choosing a vendor, but we're actually seeing it's important to have consumers involved in that. So we've been involved in the business case that failed, and the business case that was successful, and the EOI, and now it's request for tender documents. So they still haven't chosen a vendor yet. That's process, it all takes time. But
Yes, and one of my questions was in that space, what consumers are sitting on the tender group that's going to be on the evaluation panel, particularly from a mental health perspective, because there are federal documents saying you need to have a mental health consumer on there. Not to say other consumers shouldn't be on there as well, but it is part of the accreditation process. It's currently a voluntary element of the accreditation process, but at some point that will be rolled in, and they'll need to, I expect, in the next 5 years or so.
Yeah, and just in answer to that, and I hope you can hear me because I think my internet is a bit dodgy.
Yeah.
But we have now a director consumer engagement who's full-time on the program, and I work with her. So I work for Health Consumers Council, and I sort of chair the consumer reference group, and we have a director consumer engagement who's there full-time. We help shape that job description so that it's lived experience led. But the next process is to make sure that there is enough of the right input in the right areas. So yes, we do have some mental health representation on the EMR consumer reference group, but we will be looking, there are a lot of decisions that are going to be made, and we'll be looking to get that right. We're still trying to work out how do we do this, because it's,
yeah, it's new.
But the thing is, we've got set up is we've got consumer payments. We've got an ongoing thing. We've got somebody who's in there as a staff member. You've got me, who's a Health Consumers Council staff member, with support and the wisdom of people like yourselves. So I hope that's that. But let's talk offline more so that we can make sure that all gets covered. And Kieran, I believe it's comfort break time.
Yep.
Am I correct?
It is, and we're gonna go to a comfort break, and once we're back from the break, I'm gonna zip you off to breakout groups for some discussion. So I'll pop the questions up while we're on the comfort break. I thought before we go to these breakout groups, it's probably worth just recentering where the conversation sits. So as Pip just talked about, we advising the electronic medical record program, which is impending, that they're at the stage where they're looking at putting tender out for the system. It's all very early in on the piece. That being said, it's a great time to do a bit of an environment scan as a consumer organization and understand a bit of a pulse check around some of the issues, so that if we spot things, we can go and investigate them further for when department will rapidly need to make decisions around this. So we're really interested in a sort of a general overview of your feelings on artificial intelligence, perhaps some of your concerns, perhaps some of the processes that you'd like to see follow. It can be really wherever you'd like to take it, as well as perhaps some of the potential positive, some of the applications for artificial intelligence that perhaps you would like to see investigated. Because I think that the department, this may be an opinion of mine, but they're likely to focus on efficiencies maybe more so than things that as consumers we know would be really exciting for our care. So it's always good to put the question to consumers and understand, how do you think we could be looking at this technology? What areas would you like to see investigated? And perhaps because we're so early in on the piece, we can help bump that in the priority of the thinking. I'll pop the slide up on the screen for a break. We're going to return at 5:15.
And Sasha, just to say, the request for tender document's not yet public. It won't be public till 2026.
But have they not? But they said they're about to appoint off it. So if they're about to choose someone, it would have already been.
No. The request for tender hasn't gone out.
Oh, okay.
We're in the process of it. Will go out in the beginning of next year.
Oh, okay. No worries.
Yep.
So how rigorous is the review by the consumer in that document before it goes out? Because the big issue is once it's gone out.
Yeah. Well, that's to say that's Beck and myself. So Beck's working full time now. So it's stronger than it was for sure.
But are any concerns going to be relayed back to us for discussion in terms of that document, or are we totally relying on you to do the right thing?
Well, yes and no. Yes, of course. You make an important point. I think there has been a little while since we've had an update, and we are hamstrung by a lot of the probity issues. But that's an important point. Nigel, I will make sure that we get an update. But I'm just for everybody on this session, because not everybody's in the EMR Consumer Reference Group, let's have a break and let's come back and have our conversations.
Thank you, Dee.